No financial interest, but it would be nice to have some. Basically, I've been asked to touch upon some important points about phakic IOLs. And if you look at the Cochrane review, which was done a while back, where they combined the phakic IOLs with laser refractive surgery, there are very significant take-home points that phakic IOLs are safer, have better contrast sensitivity, and also have higher patient satisfaction. You look at quality of vision in terms of visual performance, the laser refractive surgery tend to have higher order aberrations. If you look purely at patient satisfaction, the results are uniformly across almost all ICLs very, very good. Of course, there are some considerations when you look at the different types of phakic IOLs in terms of the material, in terms of the sizing, intraoperative handling, is there any different surgical technique, predictability of the sizing, and post-op refractive results, and I'll touch upon some of them as I run through the presentation. At present, the present phakic IOLs available are probably most commonly across these four companies, where you have the Star, the IPCL, the Apasami RIL, and the Biotech. In terms of the material, definitely Collamer, which probably has the longest follow-up of almost about 20 plus years, with almost about 50 published results. There have been good results reported with the hydrophilic material for the phakic lenses, though the follow-ups are still shorter, and most of them have come through presentations at conferences. What is also important, especially in terms of refractive index of any phakic lens, because this prevents visual disturbance, is that the closer the refractive index is to the aqueous, which is about 1.36, the better quality of vision you would have. In terms of correction of lenses, most of them are fairly diverse. You can correct from 0.5 almost up to 18 in the Star Vision ICL, but with the IPCL, RIL, and even the Biotech, the results are almost now up to 23 diopters. What is also important is in terms of the diameter. Most of the higher myopic lenses tend to have smaller diameters, and we do know myopes sometimes tend to have pupils larger than 5.5 millimeters, and this can cause glare and halos. The other companies are making an effort to increase the optic zone, especially with the IOCare and the Apasami, but I think they still have some way to go. What is also important is you can customize it, and the IPCL and the RIL, the advantages in terms of the implantation, where you don't really need to follow the axis, you put it at 0 and 180, and that usually is enough. In any preoperative phakic IOL, these are important in terms of best corrected visual acuity, intraocular pressure, gonioscopy. Gonioscopy is important because you will shallow the angle by at least 1 grade when you put in the phakic IOL. Fundus evaluation, it's a good idea to do the OCT, and the highlighted points about AC depth and white to white are important, and based on our experience, when you're comparing optical biometers for measuring white to white, they're all almost equivalent to what you get with the OpScan, but the A-scan can have variation, so I would caution you on using A-scan depth as a factor for phakic length implantation. With respect to white, the OpScan is significantly better than the optical, but if you really want to be sure, always touch across two methods, like a digital caliper and an optical, and probably take an average. In terms of topography, if you're doing it for ectatic stable corneas, it's important that you use a topographer which has reliable readings. Specular microscopy of at least 2000 to 2200 cells per millimeter square is almost imperative. This is probably the most important part in terms of the phakic ICL surgery, that is the sizing. As I mentioned earlier, OpScan gives the most predictable, though optical biometers tend to underestimate the white to white. Manual with the calipers, which could be digital or even the standard calipers, do give a good step in the direction, but I would definitely suggest doing it across two instruments. UBM not commonly available, but probably said to give the best option. ASOCT I would probably not recommend because the landmarks tend to be not that clear with the ASOCT. This is a broad nomogram which I use in terms of white to white. When you have variability, especially you know that there can be a change in the size. So what this nomogram basically does is you have a wide to wide going from about 10.65, which is the average, to almost about 12.5, which is the normal range, and this varies with the anterior chamber depth. This is more with respect to the Visian ICL, because the change occurs at about 11.1. Anything beyond 11.1, like 11.2, it will suggest a higher power. So the factor is more in terms of the anterior chamber depth and the wide to wide. So this is a nomogram that I follow. My recommendation for using the Indian phakic lenses would be whatever the company suggests, go up by about 0.25, because we find sometimes you tend to get narrower walls than what is suggested on the nomogram. Of course, most of them have a good online software. This is with the Visian, which gives a fairly good range of what you want to correct. This is from the Apasami. Similar website also gives you, which requires input of the keratometry, the sphere, the corneal thickness, the antechamber depth, the wide to wide, and all put together, it gives you a suggested power. Especially in myopes, definitely recommended that you take the first step minus, because most of them are used to seeing well without glasses, and if you make them hyperopic post-operatively, they'll be very, very unhappy. Toric marking in all the three lenses is different. This is important because during surgery you need to look for them, especially for the toric IPCL, for the toric phakic lenses. In the IPCL, there are actually two marks on the margin of the haptic and the optic, which are two holes, two laser markings, etchings, which help you guide the positioning of the ICL. In the RIL, it is actually slightly oblique, though they have positioning holes and aqueous holes at 0 and 180, which is also quite easy to position. The toric ICL also has laser etching marks, which are actually like a line. I don't know if you can make out on the photo, but very mild lines which help you tell you where the axis of the astigmatism is. Remember, in the toric ICL, for the Visian, it is slightly different. The IPCL and RIL, you can leave it at 180 and 0, and patient would actually do well. But this is not that customized. Visian, you need to move it around a bit if you're treating astigmatism, which is off the regular axis. I use the slit lamp across the pupil where there is a vertex and the Purkinje image on the cornea as the marker. But if you have access to toric markings with the software, that's equally good. This is important because the clockwise and anti-clockwise varies across right and left eyes. Now, this is for the left eye. This is with the two PIs, and counterclockwise is when you're sitting temporally. So it's if the this is more with relevant to the Visian ICL. If it says 10 degrees counterclockwise, you got to shift the lens counterclockwise, and similarly for the clockwise. This is an example where you have a patient who requires implantation at about 14 degrees clockwise. So when you're sitting on temporarily, you need to twist it clockwise by about 14 degrees, and that will give you the present positioning. I would suggest actually to mark the position of the lens on the slit lamp before you actually take the patient, because sometimes in the midst of surgery, and if you're slightly tense, you can forget and to twist it the other way around, which will actually add to the astigmatism. This is an important tip, especially with respect to the plunger that is available with the ICL. You need to keep it in saline at least for a couple of minutes so it swells up. Only then you would get a good push when you're injecting. In terms of loading the ICL, the orientation is very important. You got to get a convexity towards you as you put it into the injector. The other important thing is that it's a very malleable material. You don't pull the injector, but pull the ICL over, pull the cartridge over the ICL and keep the ICL straight. That helps to position it well. Before you inject, it's a good idea to see the position under the microscope so that when it opens inside, you're not really struggling to twist it right way around. The other commonly asked question is, should you use methyl cellulose or hyaluronic acid? I would suggest you use HPMC. It's easier to remove. Very occasionally you do get deposits on the lens sometimes if you have thicker molecular weight viscoelastics. This is an important part, and this is uniform across almost all the ICLs, that you would have a mark on the right that is called the leading right, and this would guide the positioning. Once you have the lens inside the eye, put visco on top of the lens. It settles it down. It moves the lens back and helps with positioning of the iris, and I'll show you a short video of how it is done. This is our standard technique. This is for a toric, almost like doing what you would do for a standard toric IOL. You can use a 2.4, even a 2.8 millimeter incision. I would suggest not to really be fussy about making it small. You can make it 2.8 and it actually works quite well. And you got to, as it's opening inside the eye, be very careful, make sure that it opens the right way up. Almost last couple of minutes. The other thing was in terms of the tucking of the ICL. This is important that you use the right instrument, especially towards the wound. And tucking of the ICL is easier with the ICL rather than with the hydrophilic material, where it's a lot more tougher. In the RIL, these are slightly stiffer lenses. They are slightly thicker lenses. Remember that you put them in an IOL cartridge, so you would need about 2.4 to 2.8. When you're inserting it inside the eye, you need to have the leading right in this. And it tends to be a lot more thicker. It tends to occupy more space, especially the optic. Optic is thicker in the hydrophilic lenses. You put a bit of viscoelastic, you would need a different instrument. The haptics are also a lot more thicker, so you may struggle a bit if you're shifting from an ICL to an Indian phakic lens, but usually with a bit of effort, it goes off actually quite well. This is a video from Dr. Saurabh, just to show that the IPCL is actually quite similar. You need to make the orientation, make sure the vault is towards you as you insert it and load it, so that it doesn't open the wrong way inside. The insertion is also quite stable. You need to hold it till it opens the right way up. Don't remove the plunger, because sometimes that will cause a flip. This is the positioning of the post-op. This is the vault. On the OCT, it's a good idea to measure, aim for at least about corneal thickness. And we have actually done it even in post-keratoplasty eyes, post-DALC. If the positioning and the working is actually quite good, if you got regular astigmatism, like in this patient, 5 years post-op, he's actually quite good. I would just end with this, that in conclusion, the phakic IOL gives good predictable outcomes. It's easy to master the technique. The surgical technique is important to avoid complications, and it usually provides excellent satisfaction. Thank you.